And these are about tips about taking a good history and about comorbidity. And we did part one last time, probably 3-4 months ago. And here is part two. And part two is comorbidity is the rule in our patients. Okay. While much of the past century was devoted and really helped by addiction people making it clear that addiction can be the primary disorder and everybody's not, quote, self-medicating, unquote, for a primary psych disorder. On the other hand, sometimes we get mixed up and we think, but these people in general, it's all one disorder. And it may well not be. No matter how you got to having 2, 3, or 4, and which one was primary, you still might have 2, 3, or 4 disorders. And as noted on the case we just went through. So a lot of people get into arguments about which caused which, and I always say at some point, does it really matter? Because which caused which happened when they were 14 or younger, and now they're 48, like and they're all here. So now it's amazing how often it matters to the patient. There's a lot of resistance out there to comorbidity, and if you even start poking around, people will say, I drink or I use, I'm not crazy, and other people will say, I'm bipolar, I'm depressed, or I'm anxious, I'm not an addict. I just self-medicate. And there's this idea that you somehow, if you get too many diagnoses written on the piece of paper, that it actually, harms the self, so to speak. You just can't take it. And on the other hand, and I can understand that. The flip side is taking your eye off of all those other things is sometimes risky. So, and then there's the old AA statement, depression is an excuse, not a disorder. And we still hear that periodically. And sometimes when I get to this point where you have multiple mental health disorders and multiple addiction disorders, I think to myself, might not be so sharp, Krahn, that you can figure out which is primary and which is secondary. And you might have to figure out what's the thing most likely to kill them right now? What's the thing most likely to kill them secondly? What's the thing, what are things that are keeping this all going, etc. Now, the other thing about comorbidity that harkens back to our last talk was the incredible value of corroborative history. Trying to sort out what came first and what came second and what came third with somebody who is intoxicated for a lot of that longitudinal history is sometimes, what can I say, kind of a fool's errand. And getting a corroborative historian in, if you have the chance, if you have both the time and the consent, is remarkably useful. And with that, we're going to move on to looking at a little bit at epidemiologic studies and then looking at diagnoses. So just as an overview, we're going to talk about mood disorders, both depressive and bipolar. One take-home message that we're going to hit on over and over again is that depression is by far the most frequent comorbid condition, but in some ways, it's the least specific. Because you can be depressed and bipolar, you can be depressed with PTSD, you can be depressed with GAD and social anxiety. And so a lot of those other disorders, other than the depression, have a much more specific treatment. And if you can identify them, you're more likely going to get to something specific versus, well, let's just add an SSRI to the mix or the like. So we're going to go through these disorders. All of the stuff I'm talking about is either from the ASAM Principles of Addiction Medicine, from Ed Nunes's work called Substance and Co-Occurring Psychiatric Disorders, or from the DSM-5 section. And immediately after saying DSM-5, I go back to an old slide, but a good one from DSM-4. What's primary depression? And actually, the easiest thing to in the setting of comorbidity. And sometimes what I like to think about it is independent depression. Has it been temporally independent? Did it precede any drug or alcohol abuse? Did it persist in abstinence? Preferably current and observed is really good. You know, if you look at people coming into a treatment center with alcohol dependence, for example, something on the order of 60 to 70% on day one will meet criteria for depression, other than is it alcohol induced, but they will have the syndrome of depression. And by the end of a month, it's more like 20%. Now, the problem is that and I remember vividly in my training period and when I was just out of training, the Minneapolis VA, which had a wonderful addiction program, also had the absolute belief that you had to wait a month for anybody to get treated for depression. And the problem is that severe depression can wipe out your ability to participate in the treatment program for that critical first month. And secondly, actually by a couple of weeks in, well, first of all, if you know that there was an independent depression, that it did have onset before the disorder, or it has been there during times when there was no significant drug or alcohol use, waiting a month doesn't make as much sense. And if it's pretty severe, you probably ought to jump in sooner, maybe in a week or two. Substance-induced depression, on the other hand, is non-independent or not temporally independent. And the thing you have to look for to make that diagnosis, however, is that the severity exceeds what would be expected from the usual toxic or withdrawal effects of the substance. So finally, of course, to make clear about that, you have to know what the usual effects are. So the next slide. Oh my gosh, so there's the last one, sorry. And there's the next one, prevalence of comorbidity. Overall, for patients entering treatment for substance use disorder, in general, it's 20 to 50% lifetime major depression. PTSD, especially common, especially in females, as we just talked about, with the trauma history of females who are in addiction programs. It's not surprising. And with that, we'll put in an ad for next month's didactics, which will be trauma in women with substance abuse disorder, led by Lindsay. So come back for that one. But PTSD is especially common. And ADHD is 10 to 30%. So you're going to have a lot of people who are on stimulants. Patients with schizophrenia, 70% plus, in many places 90% plus, have nicotine dependence. Alcohol and cannabis are frequent, but all of these observations suffer from what some people call the clinician's illusion or Bergson's bias. If you are working in a place where everybody brought to you has severe disorders, they're more likely to have more comorbidity. So when you work in a clinic or work in an inpatient unit especially, you will see more and more comorbidity based on where you are located. So to offset that, we have to actually look also at community surveys. The big ones being the Epidemiologic Catchment Area Study, or ECA in the 80s, the National Comorbidity Studies in the 90s, more recently, NESARC, or the National Epidemiologic Study of Alcoholism and Related Conditions, has become one of the big ones. And the one I don't have on here is I heard somebody call it the NSDA, the National Study of Drug Use in Households. So there's a lot of data out there. The take-home message on this next slide, however, is that, first of all, in both alcohol use disorder populations and drug use disorder people, I should say, alcohol use disorder people found in the general population. So remember, alcohol use disorder in the general population and drug use disorder in the general population, most of those people aren't in treatment at all, okay? Which probably means they're also of far less severity than what you're seeing in treatment settings, or they're poor, or both. But what you see is when you look down major depression, these are odds ratios that they're going to have major depression. If you're alcohol use disorder, it goes up by up to 4-fold. But if you have a drug disorder, and this is mostly stimulants and opiates, it's up to 9-fold more likely. Dysthymia, 3.8 to 11.3. I'll just look at the top one. Bipolar, 8 and 13.9. Panic with agoraphobia, 3.6 and 10.5. Social phobia, 2.5, 5.4. PTSD, 3.4 and 3.8. ADHD, as you see, 2.8 and 7.9 for drugs. And actually, I screwed up the antisocial is from 8.3, from 118-fold for alcohol, and it's up to 54.7-fold for drugs. So sociopathy or antisocial personality disorder is by far the thing most overrepresented in alcohol and drug use folks. But you can see everything is dramatically higher. Given that this is in the general population, you can imagine how much higher it is in the treatment population. So conclusions from community studies, comorbidity is the rule there too. It varies across studies, mostly due to different methods. The odds ratios are always higher for drug disorders versus alcohol disorders. The odds ratio is smaller for depression than for a lot of other ones. And so depression may be a good signal to look for another disorder with a more specific treatment. And that's something Ed Nunes speaks on fervently, and I think is really important to remember. And of course, the thing underneath the depression, the social anxiety or the PTSD or other disorders, the panic and agoraphobia, might well be something that the patient doesn't want to talk about. And so it stays hidden. And it's been hidden by the drug and alcohol use, and then it gets hidden by the depression. But if you get there, you're more likely to create a really effective treatment plan. So prognostic implications are pretty simple. The more the comorbidity, the more kinds of comorbidity, and the more severe the comorbidity, the more severe the addictive disorder, and the worse the likely outcome. Here's another thing about being careful in diagnosis, though, in the severity issue. It is much worse to have a full-blown major depressive disorder, than to score 14 points on your PHQ screening exam, but not meet the criteria for the whole syndrome. So the disorders tend to be associated with worse prognosis than just having some symptoms. So when you think about diagnosing major depression, you've got to have anhedonia and you've got to have depressed mood. And you'll see a lot of people with addictive disorders who have terrible sleep and terrible energy and their appetite's all screwed up. And they don't feel very good about themselves, but they don't have major depression. Because if you don't have anhedonia and you don't have depression, depressed mood, you don't have it. So it's important to make that diagnosis appropriately. So there's lots of possible etiologic relationships. And the relationships between these disorders tend to be very complicated and complex. One thing I'll just mention real briefly as an example of this is if you look at the role of stress and trauma in substance use disorders, you find that people who have trauma and then develop post-traumatic stress disorder are much more likely to have an addictive disorder than people who have trauma, don't develop PTSD, and then you look at their drinking and drug use. So the PTSD is actually critical in really making trauma and addiction, making the connection between trauma and addiction. So that's one way things can be related. On the other hand, people who are addicted get in more car accidents, get in more fights, get in more, all sorts of things, and end up with more trauma, okay? But if they don't get the PTSD, it still doesn't add on as much. Now, you may still need to be aware of it because there's people walking around with subdural hematomas, and you wonder, boy, this guy seems kind of dull. Well, there's a good reason for it. It's important to avoid being simplistic, like we know the direction of all these relationships. People, you know, like they say, I am self-medicating my PTSD. Well, how did that trauma happen? How did you end up getting there? There might be actually more to that chain of events than you think. And there might be genetic aspects to things and environmental aspects to things and other sources of events that cause difficulty. Now, some things are more specific. The classic issue with PTSD, for example, is then which addiction do you get? And there's at least some data that suggests that people who have PTSD and become very withdrawn use more stimulants and cocaine. And there's other people who are more anxious and panicky end up using more alcohol. Somewhat debatable, but there's at least some data about that. Social phobics who get very anxious in social situations tend to use more alcohol than they use stimulants. And cigarettes may have the most complicated relationship because anxious people start smoking somewhat more, but cigarettes in the long run make you more anxious, but each individual cigarette makes you feel less anxious. So if you finally get somebody to quit cigarettes, 6 months later, their baseline level of anxiety is lower, but they still remember, boy, when I get anxious, that cigarette really helped me. So comorbidity is complex and important. It's really important to include both disorders in the treatment plan. And depending what door you walk into, a door with a label of an addiction treatment program or a door with a label of a mental health treatment program, you can end up having one or the other forgotten. The current thinking is that fairly contemporaneous treatment is better than sequential. It doesn't have to be completely melded, but waiting to the end, like telling people with PTSD who are, quote, self-medicating, that they have to give up their alcohol now and face the nightmares without it, you know, gets you a lot of people leaving your program, basically. So somewhat contemporaneous is helpful. Sometimes treatment becomes more complex when you're doing both things at once, but hopefully it's more complex for the treaters and not the patient. So feel free to take on the complexity. And then finally, medical comorbidities, we're not going to go through all of that, but the thing I always emphasize with medical comorbidities is the comorbidities that actually weren't caused by the addiction. Like, I can't tell you, a lot of men decide to try to quit smoking, quit drinking in their 40s. And it's the most common time in age-wise to enter a treatment program. And unfortunately, they've been sitting in bars or in uncomfortable chairs for 20 years, not getting any exercise. And they get off the bar stool, come to treatment, and they say, man, my back really hurts. And of course, nobody's done any crunchies or stretches for those 20 years, and it's not going to get better right away. So not only those kinds of neglected health behaviors, but you know, all the dental care that hasn't been done, all the other things that have been neglected are important. Family history is obviously important. Remember, none of the disorders we treat in mental health are actually more heritable than addictions. Cocaine, nicotine, alcohol, opiates rate from 70 to 40% in being heritable. Almost no psychiatric disorder gets into the 70 and 60% range. And unfortunately, one's problems are usually nature and nurture. The person who gave you your nature also does your nurture and may be struggling with the same problems. So again, I'm going to point out again, we'll talk about this, abuse of all sorts is obviously critical, but so is friendships, education, vocations, military, and parenting in understanding this. And finally, sometimes labs and biomarkers can help sort some of this stuff out. And what I often tell people is, you have two problems now. You've got the problem you came in with, and now you've got the problem that is 2019, and I'm your doctor. And I only know some of what everybody, all knowledge in 2019. And I will try my best to keep up to date, and we will do our best together to use the evidence to treat one problem, two problems, three problems, four problems, rather than to think we're going to stick our head in the sand about your other three problems. So finally, patient goals and how would they like to get there. That's in general, whether it's comorbidity or not, but it's important to get the goals to have some relationship also to the comorbid issues, or you'll be back there again. And with that, it is 1:32. I'm 2 minutes over, but we're done. So I can hang on for questions if people have them, or discussion.